Next, we're going to have David Morris come speak about LUGPA. And part of the reason we did this is that we have a lot of residents and trainees in the audience. And, we wanted everyone to know a little bit about what LUGPA is. You hear a lot of it, and how this came to be and how you came to lead it.
Well, I'm not the leader of LUGPA.
Okay, fair.
But I'm on the board. So and that's, I do lead my group. So we've heard a lot today on culture and the team. And every time I come back here, I just feel so blessed that I was selected, despite probably some arguments from Hollenbeck, for me to be able to join the residency organization here years ago. So I'll go ahead and jump right into it. So first of all, I'll just start with who I am, certainly for the residents in the room, but obviously some of you may not remember. I was here now, it's been 15 years ago, and then left here and joined a private practice in Nashville, Urology Associates, and then unfortunately ascended to presidency not long after being in the practice. So our group is now 25 doctors and about 10 APPs. I also man our clinical research department, and along with that is kind of our advanced therapeutics, our cancer center that we run. And really, for me, it was a focus on getting into a community, caring for the patients in the community, helping bring kind of academic medicine into the community. And so you don't necessarily have to stay in academics to do that. And that sort of group atmosphere and the collegiality is kind of what led me to become more involved in the LUGPA organization. So the connections that you form here will stick with you for better or for worse for the rest of your professional career. And so it's important to keep that in mind. I will point out on here that Alta Ski Resort does think that taint is an actual word, because that's Peter Fisher, also a resident at the same time. I'm out skiing with him in Utah, and you can see the same people are in these pictures. They're all people that were part of my residency experience. Our kids know each other. Our kids have grown up together. So it's kind of extended this whole sort of collegiality and bringing academics into kind of community practice has really kind of been my passion in my organization. And so then what is LUGPA? So the Large Urology Group Practice Association was the original found name. And so it's really a trade organization. It's the largest trade organization. And the reason that that's a trade organization is it's about the groups, not about the physicians. So you don't join it as an individual. Your practice joins LUGPA. It's really about leadership, advancing the care in the communities, benchmarking and sharing best practices. And it's also led to things like bringing clinical trials into community sites. That's hard to imagine unless you've got some infrastructure that's built. And so that's really what LUGPA has been about. It actually formed, Tim's group was one of the founding members back in 2008. My group was one of the founding members. And it's really grown from there. And now it represents basically almost every state in the U.S. You can see that almost a third of the U.S. urology care in the U.S. is delivered within LUGPA practices. So just from a workforce standpoint, it's a large part of the U.S. care of urology patients. And so, you've got a big pillar on one side of academia. On the other side, you've got individual small groups, but then you've got this other large organization that represents groups that are very academic, but are not necessarily housed within a single hospital. So, and Dr. Farber shared kind of his 5 Duke, kind of values for an organization. And I think LUGPA's published values fall right in line with what you'd expect to see in academic centers. Collaboration is really kind of how this all started. It's sharing those best practices between different sites. But we do want to innovate. We partner a lot with the dark side. I was very happy to hear a presentation in an academic site that involves, quote, the dark side, because it's often viewed that way in academics. They wear red letters when they walk around the hospital. And you get out in the real world and realize there's a lot that we can't do unless we partner with people that are in industry. And so the organization has recognized that, and really that's kind of one of their focuses, is trying to do the sort of collaborations that may be more challenging in an academic center. So a trade organization represents the groups. The dyad leadership model really focuses on not just the physicians. You need physician leadership, but you need administrator and business leadership. And so that is the biggest transition for those of us leaving kind of the nest of an academic site, is that we go walk into an office and have absolutely no idea how the business of medicine works. And so we're taught on the fly. Unless you did some joint program here at MBA and you got some joint degree at Ross, you are new, and it is a completely different language. And it is a very important language, because no matter how great your clinical skill is, if you can't keep the mission to go for academics, I mean, for the education and the care. If there's no margin, there is no mission. And so we have to be able to keep the lights on and employ my employees who've been with us for 10 or 15 years, just since I've been there in the practice. So the business really is kind of the focus of the organization. And then it's morphed over the years into advocacy for those business opportunities of independent groups. And so that's probably the biggest thing that they really focused on recently, is this advocacy push. Similar to the AUA, LUGPA has executive leadership training that's built into our organization. We have a whole wing, LUGPA Forward, that is basically catering to the next generation of leaders. And so for anyone who gets into the organization or gets into one of these groups, these are the processes to try to encourage them to move up what we can see kind of the ladder of academic training, but in a private organization. Advocacy, I just want to point out a few things, because that has now become such a focus of honestly academic medicine and independent medicine, is trying to maintain the ability to do what it is we do. And so the kind of the goals of LUGPA and kind of what every year has been proposed is, this is our next fiscal year. This is our next cycle year in terms of elections. Here's what we're pushing. It's very similar to what is seen from the AUA publications. And I've circled here just kind of three of the ones that are very clearly listed on the AUA website and very clearly listed in ours. This is from LUGPA, of those that we are working on the Hill to try to support. And whether it's the physician fee schedule, that actually is how all of us get paid. But you can see PBM reform. Actually, a bill just got passed recently in the House just this past week that's really trying to push access for our patients to be able to have drugs delivered to them, not through restricted networks and PBMs. And so the telemedicine, near and dear to my heart. We've had Chad come talk to the LUGPA organization when telemedicine was brand new. I mean, it exploded during COVID, and most of us have kept it alive in some manner. It is important that we push to keep it alive, because for a lot of our 85-year-old patients, they do not need to drive an hour and a half to come see me for what effectively is a 5-minute face-to-face Zoom call. So this is just an example. This was pulled from the AUA recent release email, and this is from the LUGPA recent release. That is, here's our letters of support. They're going to different bodies, but both organizations are pushing for urology care for patients. It's just coming from kind of a slightly different perspective, but almost universally our kind of goals ally, and that is being able to let us continue to practice medicine. And just as an example, this is a close friend of mine. This is networking. This is Tim Richardson, who's in the Wichita group, and he was invited and spoke at the Ways and Means Health Subcommittee earlier just in the spring. And so this sort of commentary enables urologists, not just from academic sites, to basically say, we're boots on the ground. We need to talk about how to keep urology offices open so that patients can get in to see us. And I think what I've really taken out of it, the collegiality we had here as the team, is that it has to be fun. You have to want to work with people. You have to want to show up every day. And so the networking between groups, not everybody in your group is going to be your best friend. And that is okay. Not everybody in the department is your best friend. But you better have friends that you work with every day, but you're going to have close friendships in groups that are 2 states away across the U.S. And it's fine, especially out of residency. I have friends that are on a map of the U.S. that are in every state almost, because of residency and because of these sort of organizations. So keep track of the residents when you leave. You'll know, like, oh, so-and-so went somewhere a few years ago. When it's time to come out and look for a position, that's a good person to contact if you're interested in being in that area of the country. We also have a lot of educational pushes. There's a lot of academies that we reach out to residents. It's for people new in practice. It's trying to basically educate on the best way to potentially take care of these cancer patients. We've done ambulatory surgery center academies that are really focused on the business of running a surgery center, establishing a surgery center. I'm going to have Gary Farber come to the next one because he can talk to us about running an ASC. But the networking is why you keep showing up every day. I mentioned on benchmarking is something that from a data perspective, we can collate a lot of data. This is an example of our ongoing LUGPA benchmark. It's not every single LUGPA group, but you can see here statewide, these are the numbers go along with how many groups from that state are supplying data to the LUGPA benchmarking. And you can see here just an example of urologist FTE data in terms of what over a 12-month period of time, what is the typical work RVU from someone in an independent work practice, which is right around 11,000 RVUs in a year. And so along those sort of things, you can then compare yourself across groups. The next step is looking at disease specific. And I put this in here. This is about BPH, which is perfect for this sort of meeting. And you can see basically for this, ability to look across the network, are we doing something similar to the other groups? What's our rate of using incision of the prostate, resection of the prostate, green light? What's our HOLEP rate? What's PAE, which is starting to take off even in independent groups because of basically the academic knowledge that's kind of percolating through the country. So it's important that we can do this to make sure that we're not out on limbs and that I'm doing basically what is similar to other similar size groups across the U.S. I mentioned research, which is dear to my heart. A lot of LUGPA groups function in co-op sites. Those are usually larger SUO, CTC, or SWOG sites. But we do a lot of partnered with industry sort of sponsored trials. So currently, I think I just added up our most recent, what we have. We have actually right now 16 open trials. We have 8 research coordinators for my site. I run most of the prostate programs. Tom J. Ram runs most of the bladder and kidney. It leads to a lot of early access for our patients. The sponsors love it. It's very easy. We have much less red tape at our site than you would have at Michigan. I thought it was entertaining when we were talking about opening the BPH trial. Like, I guarantee I could get that trial open in 4 weeks at my site, but at Michigan it might take 4 months and probably 3 different attorney teams to tell you exactly if that's going to be something that can happen or not. But we have experience with all of the new things before they're even out. So we've been putting tar pretzels in people for the last 1.5 or 2 years. So we've been giving belzutifan for kidney cancer for the last 1.5 years. So you have a lot of chances in independent practice to do things that are very similar to academic inclined organizations, but are still able to do it in a community. And so I just want to put this up there. There are some residents that are still probably here and maybe not back at the hospital working, but we do have some education opportunities for residents. There's a resident summit and job fair, brings together groups from across the U.S. There's presentations on hospital employment, academic jobs, independent jobs. And so this most recent one coming up is going to be in Orlando in the spring. The nice thing about these is because of industry support, we're able to pay for residents to travel to the session, pay for their hotels. So it's a good way to get exposure to potential jobs in areas that you may be interested in. We have awards that are an ability for patients to come, or the one award winner to come to our national meeting that basically cost free for them. They basically can submit an application for someone that might be interested in independent practice and why they would be good for independent practice. And that's an opportunity for us to we need good people in independent practice just like they need good people in academics. So we usually send a lot of this stuff out by email. You can sign up for the resident newsletter, and it's a way just to hear kind of what's happening in these large functional groups. And with that, usually it will keep your finger on the pulse if you're getting to the point where you're looking for job opportunities after you end. And so I just built like a list of here are the things that people think about in terms of hospital systems, things that we have access to. And I would say, depending on your state restrictions in terms of certificate of need, most large urology groups have many of these things available. So many of them have medical oncologists within their groups. They have radiation oncologists within their groups. They give radioligand therapy in their group. They're able to run clinical trials. They have interventional radiologists in their group doing PAE at their site. So all of these things are kind of the world is your oyster coming out of residency, but it's nice to have kind of well-built and designed systems on hand that you can just plug and play in terms of entering and having access to those things. So I feel really passionate about LUGPA's mission in terms of education and bringing groups together to be better. And I do think it's a nice opportunity outside of just the AUA sort of clinical education pathway. This is more about business education pathway of how can we continue to offer these things and do it in a way that is ethical and compassionate, but also keeps us open and enabling care in the community. So with that, I think are closer to getting us back on time so that you guys can get to the rest of your breaks and finish up your resident meeting here in a second. Any questions, I guess?
So not meant to be a really big question, and I know it is, so a quick answer. So I'm Craig Kosler, 2004 Nesbit member, lucky enough to work with David. So as we approach a decade of private equity acquiring large urology groups and kind of on a ship on the water with not really knowing what's in the future as far as how those will be managed, how do you kind of look towards the big picture of what LUGPAs do now, well orchestrated, but what they might be in the next 5 or 10 years with private equity having a bigger role?
I don't know how much time I have. So I specifically left that out of the presentation. No, just kidding. So I will say our group is independent. I am owned by myself and my partners. There are many other private equity owned independent groups. In fact, a good chunk of LUGPA is now owned by private equity. Honestly, there's kind of three buckets. There's independently owned by the physicians that practice there. There's the private equity shared model where the private equity owns a big chunk and then the physicians own a small chunk. And then there's like the hospital employment model. And so the trouble, the pressure on us to continue to provide, as we saw the 20% gap in terms of payments and cost versus the decline in reimbursement for professional services, it's becoming harder to remain independent. And so the pressure on many of our independent groups is just, not only is it pay for the physicians getting suppressed because we have to pay more for our services, but it's just hard to manage the risk that's coming in terms of if the system changes completely, drastically 2 years from now, I don't know that I'm going to be able to keep up with it and continue to do it in the same way. So some of the groups have done it as a way to offset their risk. It's shared risk then with the private equity people who think we're going to be able to continue to perform, otherwise they wouldn't invest in us. They see that growth curve of the silver tsunami and they're like, oh, you're going to have a ton of people who need your services. I want to buy your business. I hope, I don't love the private equity model. I'll just say that. And I don't like people outside of medicine being involved in medicine. Now, I have a ton of friends in private equity owned groups that have never been told how to practice. They're not told, what to do with patients, or we need you to do more of these because the reimbursement's better than doing these. They will say they're very hands off, but they basically take a pay cut to be able to get an upfront payment to share that risk long term. So I wish it was a system where we didn't even have them here asking to join our groups, but unless the physician fee schedule gets fixed in a way where those of us who are independent can remain independent, I'm worried about what might happen over the next 5 or 10 years. I'll just be honest, because I can't keep taking call and have declining reimbursement and higher cost of employment and continue to remain independent. But the system where it consolidates to like one hospital group or one private equity group, I just think that's bad for patients and it's bad for us. So I can get off my soapbox now, but that's my view on it. It's a very complicated thing, and I have friends in independent groups and in private equity groups. Every physician's trying to do the right thing. They're just trying to stay open, I think is what most people are challenged with right now. Thanks.